Hello, welcome to this week's HSJ Health Check Podcast. I'm Dave West, HSJ Deputy Editor. Each week on the HSJ Health Check, we bring together a group from HSJ's expert journalist team. And today I am joined by senior correspondents Annabelle Collins and Nick Carding, and by correspondent Matt Discombe. This week we are going to major on how to run healthcare services, particularly hospitals, in a time of COVID, and how to work in health services at a time of COVID. Covering issues of infection control, staff behaviour, service design, and of course testing. So one thing I've been wondering, and I wondered your thoughts, perhaps Nick. We're recording today on Wednesday, a day after the Prime Minister announced a whole series of activities which can begin again in less than a couple of weeks' time. Already various things going on that are now permitted, which weren't permitted a few weeks ago. Yet in the NHS, it appears, from one way of viewing, that a lot of things are still not reopening. It's still pretty difficult to get a face-to-face GP appointment. A lot of primary dentistry not happening. Referrals still restricted. We've hear accounts of even on the government's national daily press briefing yesterday, the final one, a member of the public asked about why they weren't able to get face-to-face GP, why you couldn't get face-to-face GP appointments, yet various other things are now going on. You can see family and friends and soon start to go to pubs and restaurants and so on. So why is this? Is the health service just kind of being overly cautious and conservative about going back to normal non-COVID care? Yeah.
I think the clearest and simplest answer to that is just two words, and it's Western Hospital. And for those listeners who don't remember this, I think it was late May, there was an outbreak of COVID-19 among the staff and some patients at Western Hospital in Weston-super-Mare, and that forced the hospital to close all new admissions for a couple of weeks. It meant that patients had to go further for their services. It put a bit of pressure on the local hospitals. But that was a very clear result of what happens if you don't take infection control seriously. So I think that's sort of the easy answer, I suppose, to the question why isn't the NHS opening up more? And that's the answer. Infection control is key to keeping spreads low. That said, a lot of trusts are really struggling to have any kind of reasonable level of activity as a result of the measures that they need to take to preserve infection control. For example, I was chatting to some health leaders in Devon where they have been really hit in terms of their theatre capacity. You've got trusts who are down to sort of 35% of their normal theatre capacity. Diagnostics is another big issue because for every patient that goes through an MRI scan, that machine has to be wiped, it has to be sterilised and cleaned, and that reduces again the number of patients you can take in a day by up to sort of 50-60%. So there is probably a sense of frustration that you have to do it, but if the alternative is what happened at Western, you might just have to accept that for the time being.
So quite a lot of complexity that people are perhaps still working through. Annabelle, you cover workforces. There are a lot of staffing issues tied up in this. Any take on why frankly it's extremely difficult to run health services in the time of coronavirus? It seems many health services, non-coronavirus health services, haven't been returned. Why do you think that is?
I think, as Nick was saying, I think infection control is one of the main reasons why elective work just isn't happening at the rate that we'd be used to. I think there are kind of two things. I think behaviour change that is kind of being asked of staff is huge. I think social distancing in many acute trusts and kind of primary care environments is incredibly difficult, even if it is being, slightly the distance is being slightly shortened by the government. It's still really difficult. This is obviously an issue in theatres and in clinical settings, and it's actually been quite interesting talking to some trusts, kind of some of the things they're trying to do to mitigate this. I think technology has been the sort of a saving grace when it comes to clinics. I've been talking to trusts who have their have virtual ward rounds, who have their consultants working from home, doing clinics from home, and in most places, I think this was completely unheard of before COVID. I think some places were doing it, but it definitely wasn't the norm. And I think this is the sort of kind of innovative kind of way of working we need, and I think it's going to take a little bit of time for people to really kind of figure out how to do things to kind of enable more elective work to go on. As well, I think kind of the environment of a lot of trusts makes it tricky. A lot of trusts are very old estates. I think that's also a problem. Some of them are quite cramped. I think there's a lot of worries as well about staff spaces, and without significant remodeling work, I don't know how trusts are going to overcome that.
Oh yeah, we'll come on in a bit to some of the more of the workforce and kind of staff to staff spread issues in a bit, but yeah. So I think both of you kind of getting at the point that hospitals and as well as care homes are kind of increasingly seen as one of the main spreaders and kind of propellers of coronavirus in the community, rather than the sort of receiver now of people with coronavirus. And looking at the latest statistics, it does look like that there's been little success in recent weeks in getting the proportion of cases which are diagnosed, which seem to be being caught in hospital rather than people coming into hospital with them. There doesn't seem to be much success in getting that to go down. So clearly a problem. And we published a leader piece on HSJ today on Wednesday, which confirms that the people at the involved in running the test and trace program, that their view is that healthcare settings are some of the biggest spreaders of the condition, of the virus. I suppose it's also worth saying that hospitals and healthcare settings, as opposed to cafes, etc. Because I mean, it's not necessarily that much more difficult to socially distance in a GP practice or an outpatient clinic than it is in a cafe. But of course, hospitals and things, you've got a lot of vulnerable people who you might not want to. Who, of course, are more vulnerable to serious ill health if they do get coronavirus.
It does raise the question, though, of should there be more frequent testing of staff and patients? Clearly at the moment, sort of the staff testing is a little bit varied, I think, depending on where you are. But there have been calls from various people, including Jeremy Hunt, to test staff sort of routinely every week. And given that the NHS has got some spare testing capacity, perhaps that might not be a bad idea. But then I suppose the flip side is that, as some people have pointed out, you then run the risk of some tests being inaccurate, therefore giving people the wrong test outcome, and then you might actually accidentally spread the virus further by sort of giving people a false sense of security. So it is a difficult question, but I can see that might be a movement that happens later on down the line if the sort of persistence of spread in hospitals continues. I think increasing staff testing is almost a necessity.
Yeah, well, come back to testing again as well. But I wanted to ask you, Matt, about this issue of the need of infection spread in hospitals and what that means for the redesign of services, because you've written a couple of pieces that come to mind about kind of an end to walk-in emergency care, and also been looking into this issue of how you try to make sure that patients who come in for planned surgery that they don't have coronavirus. Been talking to some people around that. I wonder if you could talk to us about some of these sort of service design issues that have been talked about.
Yes, indeed. It was last week where Catherine Henderson, who is the president of the Royal College of Emergency Medicine, was in the Commons Health and Social Care Committee, where she was envisaging a call before you walk system to basically prevent overcrowding and the spread of COVID-19 in emergency departments. And the way she would envision that working is a patient would firstly call 111 or another kind of remote triaging system, where they'd be advised what to do, either go to A&E, or there'd be some enhanced kind of urgent treatment centre, or kind of halfway between primary or secondary care, or a hot clinic, a same day emergency hot clinic staffed by specialists. And it sort of underlines the kind of transformation for patients and as well as clinicians, which is going to have to be considered very, very hard as we move forward. And we're consistently told that the virus isn't going to go anywhere. So this is, and obviously hospitals are liable to be one of the main places where this is spreading. And with that in mind, patients have also obviously for about a month now been given the guidance that they must isolate for 2 weeks before having elective surgery. Now, at the time, I had a few conversations with some medical directors and leaders of NHS trusts, and a few raised some concerns to me about the kind of behavioural aspect of it. So some patients, you might tell them to self-isolate along with their whole families as well, and their whole household anyway, for 14 days. But there was a bit of pessimism expressed to me that many patients just will simply not do that. So it'd be a lot more effective just to say, I self-isolate for a week, and there's more chance of them complying. I mean, I've also heard purely anecdotally that some patients are being told by some clinicians being told to self-isolate for 2 weeks after they're discharged. Now, that's nowhere in the NHSE guidance, but it's just something I've picked up. So those are two examples of service redesign and changes which are going to be necessary going forward, which are quite radical, I think it's fair to say, as compared to the previous world, as it were.
Yeah, it kind of makes me think about a couple of things come to mind. One is that your point about this thing that was some floating around about should people be isolating after being in hospital, which in a sense makes some sense, doesn't it? Because if they are the places where coronavirus is spreading more than anywhere else, then if you've been an inpatient, then why not? On the other hand, that's a big ask, and you want a lot more. Whereas in some hospitals, there's apparently very little or no coronavirus, and you want something more specific, coming back to testing and so on, to say whether you actually do have it. The other thing that I think might be a running theme is about thinking of the issue of trying to ban, although they will never quite say it, the issue of trying to prevent and essentially ban walk-ins to A&E or make it very, very difficult. That during the outbreak, many services, particularly urgent and emergency care services, in terms of primary care and urgent access primary care, and A&Es and urgent care centres and everything, have seen a big fall off in activity. They've gone pretty quiet, and of course, unsurprisingly, for places that are normally way too busy, there's been some big advantages to going very quiet, hasn't there? And so now, in addition to the infection control issues, both sides are kind of thinking, well, we'd quite like to keep this kind of more sensible workload. We don't want to go back to anything like normal, where we were way too busy and it was not a very sensible way of working. In the case of A&E, or the kind of corridor care, and in the case of general practice, the constant talk of being burned out and patients not having enough time for appointments and so on, and not being able to get access to appointments. And now both sides, there's a kind of a question about, how quickly is that demand going to return? Is it all going to return? And I think we've heard from, indirectly from NHS England, that they're kind of optimistic that some of the minor A&E demand might not return, but we've also got a sort of, I think, an emerging standoff or tension between primary and secondary care about who's going to take on these, who's going to sort of be the ones who receive the patients, with the question yesterday in the briefing from a purely anecdotal case of someone who appeared to work in a hospital saying general practice is not accessible, so people are starting to flood our A&Es, whereas I've heard similar from the other side, from general practice, saying hospitals are not providing any inpatient appointments, so people are, and so therefore work is being dumped on us. And the really important question at the centre of that being, is all that demand going to come back, and how quickly? Nick, go on.
Yeah, I was just going to say, again, just going back to my conversations with people in Devon, they were saying that they are now almost at sort of 90% of the emergency department activity. So they're already back to not quite the levels pre-COVID, but actually, and they said they were a bit surprised that it sort of increased so quickly. But that was quite a stark figure that sort of stuck in my mind, because I assumed naturally that it would take some time before ED activity went up to levels seen before.
Well, yeah,
COVID.
and considering a lot of, some of what has not been coming in will have been to do with other infections spreading, people going out and hurting themselves, people going out drinking, which we can surely only expect to increase over the next few weeks as sort of various flavours of fun and mixing are come back into being permitted. Then going into heat waves and then in a few months' time into winter. Okay, so let's come on to the issue of staff to staff spread in particular. And Annabelle, you've written a piece about this week, so could you start off?
Yes, no, my newsletter's on this week. So it was actually a story that kind of got my interest at University Hospitals for Morecambe Bay. It's kind of a team of 40 paediatricians were all sent home, and the service was transferred to another hospital in the trust, which is obviously quite an extreme example, but it's certainly not alone. Like, we've had other examples of teams being sent home because they've had face-to-face meetings, and that was a bit earlier in the pandemic. But I think this is a trend that's going to continue in the NHS and in other care settings, and I think it's going to continue to be a big problem. I think, it's hard, very hard. You can't separate this from the issues of PPE and then the issues of kind of tracing and the effectiveness of the track and trace system, and whether it's a nuanced system. I think it's really kind of impossible to completely separate it out. But if we're just talking about kind of solely infection control and trust, like I kind of hinted at it a bit earlier, but the difficulty that many face, I think some are at a disadvantage from the beginning, just because of the way their estate is configured, and the fact that staff are working in very small meeting rooms. I've spoken to people who've had kind of porta cabins put up in the grounds of trusts to act as offices, because that they just don't have the space to socially distance. And you're spending, and we're talking about cafes earlier, but generally in a cafe you sort of tend to pop in and pop out, and you don't tend to linger too long. But I think in hospitals, the amount of time that people are spending in that space, 12-hour shifts, 13-hour shifts really aren't uncommon at all.
I was talking about patients in my defence.
Oh, okay. But I was just thinking, it's just so much more difficult, and I don't know how. I think it's going to take a lot of careful, continuous sort of auditing of staff areas and work desks and hot desking as well. I mean, it's an issue in the private sector, but I think in the NHS, no one really has their own desk at all. It's just not a thing. So
it makes me wonder what Robert Naylor's thinking, because his review was very much about, reducing your estate and maximising the space you've got and trying to cut down on sort of non-clinical areas. It's not quite what you need for a pandemic, is it? It's got the opposite, which you need now. You need bigger space and more.
Well, I think we talked about before on the podcast, it depends what you read into the home working, whether people who are non-clinical, whether what proportion of that will go to home working, I suppose, because we've also talked about I've talked with other people in the team about discussions about particularly commissioning, sort of selling off, looking to end leases and sell off their land because they've gone to home working and don't really expect to go back. So, but yeah, in terms of design of hospitals, it's completely upends things, and I think it raises some questions about sort of how come infection control hasn't been given a bit, seeing as infection control was already a major aspect of patient safety. We've had everything about MRSA, C. difficile, and so on. Does raise some questions about what aspects of infection control weren't being taken that seriously before anyway.
And I think the change in guidance as well, particularly around mask wearing, so kind of explaining to staff why it's important to do something a certain way and to only wear PPE in certain situations, then obviously that was kind of flipped on its head a couple of weeks ago, and now all staff are required to wear PPE even in non-clinical areas, which I think now it's kind of become clear that staff to staff infection rate, particularly among asymptomatic staff, is the major way in which it spreads around a hospital. Because as you previously discussed, there's sort of very stringent measures in place for people coming in for electives. But yeah, I think you're asking people have to kind of completely change how they work, and I think that's much easier said than done. Yeah.
This is slightly coming back to the issue of actual service provision and treating patients, but you were looking at that new advice from the Royal College of Anaesthetists, which I thought was interesting.
Yes, no, absolutely. So this is quite recently published, and it's essentially kind of because of uncertainty surrounding PHE guidance and kind of an uncertainty of how to kind of apply this in local areas. And it's basically kind of encouraging multidisciplinary teams, infection control teams in localized kind of areas to have conversations about how much PPE should be worn in kind of certain environments. I think it's sort of it shows that I think hospitals, it's kind of saying to hospitals, well, you need to take responsibility for the amount of PPE that your kind of clinicians are wearing. And I kind of spoke to them today. Actually, it's quite interesting. I was wondering how can they ensure that this isn't used as a tool to use less PPE to save PPE. But I think they're quite clear that they don't expect this to be the case. I think they expect it to be used very responsibly. But yes, it's interesting. It shows that perhaps the national guidance isn't quite enough for some of these kind of groups, and perhaps that could be, as we were discussing earlier, maybe that's a barrier in getting electives kind of up and running again, this kind of uncertainty about how to make things safe. So maybe kind of more pieces of guidance like this could be quite helpful.
Yeah, although what struck me about it was all their recommendations was sort of largely about making local, very local decisions. The team having to look at their particular circumstances and make a decision about what this was for. I think it was kind of about what would likely be elective care, wasn't it? But you look at their local circumstances and decide what was needed. Whereas until now, the PPE issue has been one where it's set nationally by PHE, probably with a lot of sort of political as well as NHS input, and then it's kind of the implication is it must be followed to the letter, although of course supply has been falling short of that, but it's been a sort of thing handed down by PHE and kind of tablets of stone, whereas the anaesthetists were saying, well, actually you're going to have to just decide based on which still resonates with me about this idea that actually clearly healthcare services are going to be really careful about spread and about the risk that they're going to pose to patients if they do spread coronavirus to them and to staff the other way, and etc. But they are going to have to they're having to work in a way that's not about just straightforward rule following. They're going to have to work in a kind of more day-to-day and case-to-case basis about how to do things.
And I think their point was that it's all about the detail and kind of drilling down into the detail and what kind of a specific patient, a specific case needs. And I think that sounds sensible, but I also think that sounds very time-consuming, and it will involve a lot of people. And I wonder. Yeah, exactly. And I wonder kind of on a practical level, how ready are teams and trusts that, as Nick said, are now seeing a huge, pressures in other areas. How are they kind of prepared to do this sort of very kind of, very detailed kind of analysis?
Okay, Matt, you had your hand up a minute ago. Do you want to?
It's it's kind of passed me by a little bit with the points about staff PPE, but I've been speaking to a lot of people about antimicrobial resistance recently. Now, as you can probably expect, COVID-19, most of the impact on that hasn't been good, because a lot of patients were coming into ICU and be given a lot of broad spectrum antibiotics. And there's a fair bit of pessimism about what that means. But I've heard a couple of reasons why this whole period might not have been as bad in terms of infection control and AMR as you might think. I mean, for example, with fewer people coming into hospital, there's fewer people to kind of to get these bacteria, and also with COVID, infection control and AMR at the forefront of people's minds like they'd never have been before. So I just thought I'd inject a little bit of positive aspects of the last period. Clearly, COVID-19 is going to have a very adverse issue in some respects in terms of infection control, but there are mitigating factors which I think we need to consider too.
So why is it not as bad for AMR as you might have thought, with lots of with lots of drugs being sprayed around?
Well, I would the point which is being made to me is that obviously with a lot of antibiotics being pushed out to people, dished out, yes, broad spectrum to start with, because clinicians didn't really know too much about what they were dealing with. I'm told the understanding is a lot better now, and they're a lot more specific about which patients get which antibiotics. So there's that understanding which has been built up. More clarity around PPE is going to help. The fact that we're talking about service redesign, such as call-ins for emergency care and for 2-week isolation periods before going to hospital, and just having infection control and hygiene at the forefront of people's minds literally all the time, might mean, it has been put to me, this is not just me saying this, it's been put to me by some experts, that it might not be as bad as we might fear. But obviously that remains to be seen when the data comes out, maybe later this year, on trust resistance figures.
Yeah, certainly in the community, you're going to have a lot more people thinking about. I mean, it's a different issue, I know, but in terms of communicable disease, people thinking about what they pick up in winter and so on. So, Nick, let's dive a bit more into the testing issue, because testing, along with evidence of the drugs that actually work in fact, but along with that, testing is seen as a kind of a great hope of getting on top of this, and in all sorts of respects, but in particular how to run healthcare services, how to try and stop staff becoming vectors of the infection, and how to run healthcare services that's safely. I've got a bit confused about, because I think the NHS said a few weeks ago that it's been kind of implying for the last few weeks, it's been suggested that should really be trying to test as many patients as many times and staff as many times as possible, given the capacity that's there. But I've seen some contrary things lately. What's the situation on that?
As far as I'm aware, there's not been any sort of further official guidance or change in guidance from what was published, I think, back in sort of mid to late May, and I think it was actually Matt that wrote a story about it, and it set out that all emergency patients should be tested on admission, and elective patients needed to self-isolate for 14 days. I don't think there's been any sort of official change since that, unless I'm missing something obvious. But I would be surprised, as I said earlier, if at some point there isn't a more sort of stricter rules on how often you should be testing your staff. It sounds like from what I've read and from what I've heard, that the staff to staff infections is sort of more of a worry than patient to staff or patient to patient. So it seems to make sense to me to test staff much more frequently. And I appreciate, as I said earlier, there's that risk of giving people the wrong result if the test is inaccurate. But I think that might be one of the next sort of bits of guidance that might come out, is just to reinforce the importance of testing staff and maybe giving them, more clearer targets on, you must test your staff X amount of times per week or month. So that's the direction I would imagine that we travel in. And then, of course, as I said earlier on another podcast, there is also an increased focus on trying to get much faster tests with a faster turnaround time into hospitals as well. They're working on tests that can be turned around in 20 minutes, tests that can be turned around in an hour. I think those kinds of tests are also likely to be quite game changing potentially, and so there's a focus on getting those more developed and into hospitals as well.
Yeah, someone I was talking to was pointing me to this example of a test which in theory could I quickly identify coronavirus, but also other infections over winter, so flu or whatever, which is going to be very, very difficult to distinguish, I imagine, coronavirus symptoms in winter from other infections. So explain a little bit more this kind of false positives, false negatives concern at the moment, why that's being used as an excuse, or a reason, I should say, for not testing all staff.
So I'm sort of starting to get out of my comfort zone a little bit on this, but my understanding of it is that, any pathologist will tell you, no, there is no such thing as a perfect test. And if you are if you're a member of staff that has symptoms, you get tested and you're given a false negative, then of course you think you're okay to continue working, and you may then go about your business and infect a lot of people. If you're a member of staff and you're given a false negative, false positive, then you have to go home and get told to isolate, and you may then obviously affect other people who you're working with, who may also be told to go home, as happened at Morecambe Bay, and then you're all self-isolating for no reason because your test was a false positive. So those are the problems that can emerge, because as the pathologists say, there is no such thing as a perfect test, and that's why you have to be careful with it. But yeah, it's one of those,
and this appears to be publicly, considering this is more of a significant issue now, actually, for a prevalence of the virus is lower, because if you've got 100 people, like, most of them are going to test negative, and so actually a small number of false positives or false negatives is actually quite a significant becomes a significant thing. Rather than if 70 or 80 of them have got coronavirus anyway, then one or two either way isn't that significant. And similarly with patients, I guess it goes to the fact that you're going to be splitting how you treat them according to the results you get, and therefore corrupting things. Okay,
that's right. Yeah, but I suppose with patients, even if a patient is given a false negative when they're actually positive, I'm not I don't know how real this is, but just because the sort of prevalence of patient to patient infection seems a lot lower, I'm guessing that's partly because patients are just kept. I suppose it's easier to socially distance patients if they're bedbound, and they don't have to come into contact with each other as much as staff would, who are moving about freely, perhaps.
Okay, I think a lot of it speaks to me about a lot of this is still uncertain, and perhaps that's why the health services are taking a while to get their head around how they can return in terms of face-to-face services, on what they can return, and how quickly. That there's still a lot of uncertainty and a lot of changing factors. So thank you, three, and thank you everybody for joining us. We've come to the end of our half hour for this week. Please go on to your Spotify or Apple and subscribe, and please spread the word and send us any feedback if you've got it. Thank you.
Thanks.